Hello everyone. So today we are going to be talking about blunt trauma to the chest. There are so many um, regions in the chest that can be affected in an individual that suffers a blunt injury to the chest. The tracheobronchial tree can be disrupted. There could be injury to the lungs, in which there is pulmonary contusion. There could be damage to the ribs, like flare chest. So we are going to be picking them one by one, and we'll analyze what they entail. So the first one is tracheobronchial disruption, right? And this is just injury to the trachea and the bronchial airways. And how is this patient going to present? They are going to have respiratory distress. Of course, that is the airway. They will have problems with breathing. So there's going to be respiratory distress in form of difficulty in breathing, shortness of breath, tachypnea, right? There could be injury to the blood vessels within the airway, so leading to hemoptysis. So this patient might be coughing out blood, right? There could be sternal tenderness. So sternal tenderness, because you remember the anatomy of the trachea. The trachea bifurcates at the sternal angle into the bronchial airway. So if you palpate the sternum, you can feel the pain. The patient can complain of pain by the time you touch those areas. And of course, disruption of the airways, there's leakage of air into the tissue surrounding the airway, so causing subcutaneous emphysema. So, and we know the way they are going to present when they have subcutaneous emphysema. You are going to see swelling of the the upper part of the chest, the neck. The tissues there are going to be swollen. If you palpate that area, you can even feel for the hair tracking. You can hear the crepitus, right? And of course, there's something we call the Hammond sign. So Hammond sign is just more like a crunchy, lapsing sound, you know, which is produced due to cardiac contraction um, rubbing against hair within its surrounding tissues. We know that the heart is within the mediastinum, so this hair is tracking around the mediastinal structures, like the heart. So when the heart is contracting, right, during systole, it's kind of rubbing against this healthy tissue around it. So that brings about the hammer sound. So the rapsing, crunching sound you hear as the heart contracts. So don't forget about that. The respiratory distress, the hemoptysis, sternal tenderness, the crepitus, and other features of subcutaneous emphysema. Very common in people with tracheobronchial disruption. Um, because of the hair leakage, you can have the hair, escaping into the pleural space, escaping into the mediastinum. Of course, part of what is causing the subcutaneous emphysema is still the pneumomediastinum. Hair is just escaping into the mediastinal space, tracking within the subcutaneous tissue and going into different places. So you can see thorax by the time you do your chest x-ray, you can see features of pneumomediastinum, which we are going to see beneath. So this is a radiograph that is showing, an individual with tracheobronchial disruption, and we can see opacities, right? We can see hyperlucent areas, rather, not opacities, hyperlucent dark areas, right, just outside the rib cage. So these are the surrounding tissues, right? You can see this dark area. So this is hair leaking outside to the subcutaneous tissues, right? So it's subcutaneous emphysema, and we can see um, the mediastinum, which is a space in between the lungs, right? So all this area is just more like the mediastinum, and it's occupied by the heart. And um, pneumomediastinum tends to appear like a form of linear or curvilinear lucency that delineates, the mediastinal structure. So here now we can see this dark area. So you can see that it's kind of outlined. So this is the hair tracking within this mediastinal structure, and you can see it here too. It's kind of you know present here, but let me show us another image that actually makes it much more clearer. So this is it. We can see this is the lung, well outlined. We can see the cardiac shadow, and here we are seeing the hair, the gas, right, delineating the border of the heart. So this is very classic for pneumomediastinum. So you can see it here too. You can see that it's well separated. Like this is a cardiac shadow, this is a lung, and this is the hair right? So this is much more clearer than what we have in our first state. So that's my pneumometers, very important in a patient, with tracheobronchial tree disruption. So one thing, most of the time, the definitive treatment is actually surgical repair. Sometimes you might want to place a chest tube, right, to empty the air within the pleural space, the pneumothorax that they have. So you'll notice that because the airway is kind of disrupted, so it means that you are like opening a tap. So air will continue leaking out, right, into the chest tube. It will stop. It will continue leaking out because you have opened the tap. Unless you conceal that tap, it will not stop. So persistent hair leak, by the time you do your chest intubation, if there's a word like that, by the time you insert your chest tube and you're having persistent hair leak, think about tracheobronchial injury. We have talked about this before too. I've talked about it in penetrating injury to the chest. So, continuous hair leak, you are having pneumothorax, you are still draining like maybe like 1005 mils of hair is entering the chest. It's not stopping. Think about tracheobronchial, injury. Very, very important. Very, very important. So moving on to pulmonary contusion. So we should not get confused about this. It's very straightforward, very easy to diagnose. So this is just more like a condition in which you have bruising of the lungs. So there is a bruise to the lung tissue causing injury to the pulmonary capillaries, right? Causing extraction of fluid into the alveolar spaces. That's just what is happening here. They just injury to the capillaries, injury to the vessels, leading to fluid escaping into the tissues. Interstitial fluid accumulation. Very easy. That is it. Following trauma. So one clean chart we must always remember with respect to pulmonary contusion is that the respiratory distress symptoms occurs within 24 hours. So you don't confuse this with ARDS. ARDS symptoms will happen um, after for the imaging right now. For the imaging now, you are going to see the imaging effect, which is the edema within 24 to 48 hours for ARDS, right? But for contusion, the symptoms, the imaging features, which is edema, is going to be seen within 24 hours. So that should heighten our suspicion for pulmonary contusion. That's number one. You seeing the evidence of interstitial fluid accumulation within 24 hours should raise your suspicion for pulmonary contusion. If it occurs in a child, it should raise your suspicion for pulmonary confusion. If it's not bilateral, if it's unilateral, in fact, that rules out ARDS completely. So you are seeing just unilateral, fluid accumulation. Think about pulmonary contusion. So now, how are they going to present? So somebody suffers a chest trauma, right? And within 6 hours, they start presenting with tachycardia, tachypnea, hypoxia, shortness of breath, right? And we did our CT. Let's say we did CT or we did the X-ray, and we are seeing patchy, irregular, unilateral infiltrates with no anatomic restriction. So that means that it can affect so many lobes at the same time, right? It is not confined to one lobe. It has no anatomic restriction. So the word patchy is very important. The word patchy infiltrate, which is unilateral. Most of the time it affects one side, right? Patchy unilateral infiltrate on the chest X-ray, with no anatomic restriction or not confined with by a certain, confined to a certain lobe, raises your suspicion for pulmonary contusion. And of course, it occurs within 24 hours. You are going to see all these infiltrate within 24 hours, right? So don't forget, it's just due to bruising to the pulmonary capillaries, leading to extraction of fluid into the tissues within the alveoli, right? So because of the fact that it's related to a form of tissue leak, tissue fluid leak. So that means that, no, not tissue fluid leak now, but intravascular fluid leak into the tissue. That's what I mean. So because of that, you have to be very careful with the amount of fluid that you give so that you don't over resuscitate and further worsen the edema, right? So it's just like a patient that has, laryngeal edema from any cause, right? So you have to make sure that you are taking care of the airway first before you even give fluid, because if you overload them with fluid, it can worsen the edema and you can, worsen the problem. So same here. They're already having fluid leaking out of the vessels into the tissue space. So you don't want to overhydrate them so that you don't worsen the hypoxia that they already having. So don't forget about the features on X-ray: unilateral patchy infiltrate on X-ray, right? Not restricted by the lobar anatomy. Um, you have to be very careful with intravenous fluid. Sometimes they might, progress into respiratory failure, so you might need to intubate as early as possible, or you can even try the non-invasive positive pressure ventilation, depending on severity of the condition. So you might try your non-invasive pulmonary pressure, positive pressure ventilation first. But if the patient is very bad, the patient is already having Holter sensorium, the patient is so drowsy, lethargic, you know, very low GCS like maybe 7, you have to intubate that patient immediately. You don't start with NPPV, right? So just like I said too, it's very common in children. So this is a problem, of children, very common in children. In fact, when it occurs in children, they don't have actually a rib fracture, right? Because the chest wall in children, it's kind of elastic, so it can easily transmit the kinetic energy from the impact. So if there's an impact, there's a trauma, bam, to the chest, that can generate some form of kinetic energy, and that kinetic energy, that energy of motion, can easily be transmitted to the lungs, right? Because their their chest wall is elastic, so it can easily transmit to the lungs without breakage of the ribs. So because their lungs, their chest wall is less rigid and highly elastic, so it does not provide enough protection, right? So pulmonary contusion is very common in children. So flayed chest is another stuff that we need to know. So it's another problem that can happen in people with blunt trauma to the chest. They can have flayed chest. And what happens in flayed chest? You just have a condition in which there's a fracture of 3 adjacent ribs. So you have number 1, let's say 1, 2, 3. Or which example? This example we are having here is not 3. So this is just 2, but the one here too is 2. But what they are essentially telling us is that you have 3 adjacent rib, 1, 2, 3, fractured at least 2 points. So you have like rib 1 fractured here and here, rib 2 fractured here and here, rib 3 fractured here and maybe here. At least 3 adjacent ribs fractured at least 2 points, right? And this is going to cause a paradoxical movement of that segment, because that segment is going to be isolated from the rest. So it's going to move in a paradoxical direction. And what is this paradoxical direction? Ideally, during inspiration, you expect the ribs to move outwards, right? Because you when inspiration wants to happen, the first thing is for the diaphragm to contract. When the diaphragm contracts, diaphragm moves downwards, right? So basically, this is inspiration. Diaphragm contract, diaphragm move downwards. So when the diaphragm moves downwards, what happens is that there's generation or creation of a negative intra thoracic pressure here, and that negative intrathoracic pressure tends to help to suck in air, into the chest cavity, right, causing expansion of the lungs. That's essentially what happens. So you should have your chest wall moving out, right, when air is coming in, you know, um, in preparation for the air coming in. But with flayed chest, that doesn't happen. What happens is that when the diaphragm contracts, right, the other non-flayed chest, they are going to, try to generate that negative intrathoracic pressure, and they are going to expand in their volume, because remember that volume, according to Boyle's law, volume is inversely proportional to pressure. So when the diaphragm contracts, um, the it's kind of when it contracts, there is outward movement of the chest wall, kind of creating when they because when they are moving out, it's like you are increasing their volume, so they are creating a negative or a lesser pressure. Let me use that word. So they are creating a lesser pressure so that you can have like a an attraction, for air to come in. Because here we always move from area of high pressure to low pressure. So the diaphragm contracts, the chest cavity expands, their volume kind of increases, the pressure within that area decreases so that you can have air coming in, right? So, but in flare chest, that doesn't happen for the deflate segment because they are disconnected from the other ones. So by the time the diaphragm is contracting and the other ones are moving outward, they don't move outwards. So the negative intrathoracic pressure that the other non-flare chest is creating is going to take it inwards. That is exactly the problem. It's going to take it inwards. So they move inwards. And by the time they move inwards, they are not going to allow that chest cavity to even generate enough negative intrathoracic pressure to drive in here. So this might sound confusing, but what I am just trying to tell us is that when the diaphragm contracts, there's kind of like a space for the chest wall to expand, to move outwards. And when the chest wall move outwards, their volume increases. Volume is inversely proportional to pressure. So that means that the pressure reduces. So there's a negative pressure. And that negative pressure creates like a scaffold, like an avenue for hair to move in. Because hair will move in from higher pressure to lower pressure. Very easy. But when there's flare chest, and the diaphragm contracts, move downwards, the other ribs that are not flared, that are not broken, they will try to move, outward so that they can generate a negative intrathoracic pressure. That little negative intrathoracic pressure that they are generating, we pull this flayed segment inwards. It kind of sucks this flayed segment. It moves it inwards. So it means that it is not going to participate in the outward movement to generate enough negative intrathoracic pressure. And when you don't have enough negative intrathoracic pressure, there's no way you can take in sufficient amount of air. So that's why there's an impairment of respiration. And of course, there's going to be dead space ventilation with flare chest. So that is the mechanism. And another mechanism, of the impairment of respiration in people with flare chest is the fact that the broken ribs can contuse the lungs, right? They can cause pulmonary contusion. And the third is the pulmonary splinting from the pain. So because of the fact that the ribs is broken, they feel pain and they kind of find it very difficult to breathe. They don't want to breathe because if they breathe, it causes some traction, some movement within the broken ribs, which elicits pain. So they would rather want to keep still or they have shallow breath. And that increases the risk of lung collapse because if you are not taking in air into the lungs will collapse. So there's a very high risk of bisal atelectasis because of the pulmonary splinting from the pain that people with flare chest experience. So part of the management is what? Pain control. Number one stuff. Control that pain, right? Support their ventilation, right? Give them oxygen. Administer a positive, airway pressure. Give them the PPV. Put a positive pressure to that airway. Why? Because you have already said it, that what is sucking in that flayed segment is what? The negative intrathoracic pressure. So why don't you administer a positive pressure to bring everything out, right? So that is how you can help them. So administer a positive pressure to bring everything out and open that space, so that you don't have any flayed segment moving inwards during inspiration. So we have talked about the basis of flayed chest. We have talked about the fact that we have like flayed ribs that are broken that doesn't allow for generation of sufficient negative intrathoracic pressure. We have talked about the fact that the broken ribs can contuse the lung tissue and it can impair ventilation. And the last part is the pain, the pulmonary splinting. the pain, so they don't want to breathe, so they are kind of splinting, you know, um, because of the fact that they are scared of breathing because it generates pain for them. So you have to do adequate analgesia, you know, to control the pain. You support their ventilation, and the like. So respiratory compromise in flared chest occurs majorly because of the pulmonary contusion rather than the flared chest. So the pulmonary contusion plays a very significant role in the ventilatory impairment. So you have to know that. Please, we have to be careful. We should not see the question and be rushing for contusion. It's good we have it at the back of our mind, but sometimes you might see myocardial contusion. The question stem. Don't go for that. If you don't see pulmonary contusion, look out for problem with, generation of negative intrathoracic pressure. Any one of them will be correct, right? And of course, we have talked about the fact that you need to control the pain and you need to assist them with a positive pressure ventilation, which is basically the mainstay of treatment. Most of the time, you don't need to do surgery, but in severe cases, you might need to fix the ribs surgically, right? If it's very severe, you might need to fix the ribs surgically. But most of the time, the question stem, I'm serious. You are definitely going to see stuff about pain control or administration of a positive pressure ventilation first, right? So, um, damage to the first rib, the scapula, the sternum, they are very strong thick bone, which is difficult to break. And when you have fractures affecting the scapula, the first rib, the sternum, they are kind of connected like a ring. So, and they are very strong. They can withstand high, blunt force. And if they finally give way to the force, it means that it's going to avoid so many vessels. And the aorta is just looping around that area. So they can have aortic disruption because of that. So watch out for that, aortic disruption. We are going to talk about that by the time we get to um the blunt cardiac injury. Um, Unilateral diaphragmatic paralysis. So it's another stuff that we also need to know. The tracheobronchial tree can be disrupted. We can have pulmonary contusion. We can have flared chest. At the same time, there can be injury to the diaphragm, right? So the way I see this diaphragmatic paralysis that it might be a motor problem or it might be like a nerve problem. So either like when I say motor, like the muscle, right? The muscle, the diaphragm muscle itself, and the nerve sometimes. So the nerve that supplies the diaphragm is a phrenic nerve, right? The phrenic nerve supplies the diaphragm, and it occurs from, it originates from the neck, the C3 to C5 portion of the cervical region, and it descends downwards, looping around the anterior scalene. So anterior scalene muscle is one of the landmarks that you use to, pick up the phrenic nerve quickly in surgery because it kind of winds around the scalene muscle, then descends over the anterior aspect of the pericardium before now moving downwards to supply the diaphragm. So it kind of provides some form of sensory innervation, sensory and motor innervation through these structures it's passing across. Um, so because of the fact that it descends from the cervical vertebrae, so there's a potential for injury at that site, particularly in situation of Pancoast tumor, in which you just have the tumor originating from the sulcus of the lung, just at the tip of the lung, like at the superior border, which is very close to the neck. So if a tumor is there, it can easily compress on the cervical vertebrae, particularly the C3, C4, or C5 aspect, compromising the phrenic nerve. So that's why a lung tumor is one of those things you look out for if a patient is presenting with a unilateral diaphragmatic paralysis. It moves, downwards and looping around the anterior scalene muscle. So anybody that has like injury to the neck, destroying the anterior scalene muscle can have diaphragmatic paralysis. It moves across the anterior pericardium. So individual going for cardiac surgery can easily have injury to the phrenic nerve because it moves across the pericardium, right? Before now moving downwards to supply the diaphragm. So anybody with blunt trauma to the abdomen, to the chest, can both have diaphragmatic paralysis because of the cause of the nerve, right? Um, so when we say unilateral, it means that it is one side of the diaphragm that is affected because the diaphragm is two, the right and the left. So um, if it's only one that is affected, sometimes, most times, they are asymptomatic. They don't have any symptoms, right? Most of the time, you might not even know that the diaphragm is paralyzed, right? But sometimes they can experience exertional dyspnea. So by the time they start running, they start jogging, and there's increased work of breathing, they need to take in more air, right? And I must say that the diaphragm is a primary muscle of inspiration. Like, you need it during the inspiratory phase. So it's the most important muscle there. So when they need to get in more air, that's where the symptoms start showing. So they start having exertional dyspnea, they start having autopnea, right? This is because when an individual lies down, so you tend to have like a force, like gravitational force, kind of pushing the abdominal content upwards, right? So because when you just picture that somebody's standing, when you stand up, the abdominal viscera move downwards. But when you sleep or you are lying supine, they kind of gravitate upwards, compressing on the diaphragm, moving the diaphragm upwards. Don't forget, when the diaphragm wants to help in inspiration, in which direction does the diaphragm move? We are going to answer that question ourselves. Where does it move? The diaphragm is supposed to contract and move what? Downwards. So it means that the diaphragm is going to be struggling by the time you are sleeping, because when you are sleeping and you're lying supine, the abdominal viscera is going to be pushing upwards on the diaphragm. So that means that the diaphragm has to be fighting against that force, right? This diaphragm is already weak. So that means that if somebody lies down, that problem, so they are going to be having autopnea, right? When they lie down, or they have decreased, exercise tolerance. So when an individual is lying down and the person wants to breathe, the person wants to take in air, it becomes a problem, because that diaphragm normally should contract and move downwards. But as it's trying to move downwards, now encountering a force that is pulling it upwards is a problem. So they are going to have autopnea. So something that looks like heart failure, but this is not heart failure. We are not going to be seeing the leg swelling, the edema. So pay attention to that. So the exertional dyspnea, the decreased exercise tolerance, your autopnea, can occur in an individual in unilateral diaphragmatic paralysis. But this is much more common in people with the bilateral. Most of the time, unilateral, they are asymptomatic, right? But they can have these too. But anybody with the bilateral definitely is going to have all this. They are going to have all this. So um, before I move further, I was trying to mention some little stuff that causes diaphragmatic paralysis, and except for unilateral, usually it's like due to trauma, abdominal trauma, chest trauma with injury to the nerve, um, people with lung cancer, sulcus tumor compressing on the pharynx, people that undergone cardiac surgery, destroying that nerve as it moves over the anterior pericardium, they can have unilateral paralysis, right? Most of the time, if it's bilateral, think about the muscular disorders. Think about stuff like ALS, like polio, like um, multiple sclerosis. So multiple sclerosis, ALS, polio, Guillain-Barré. Guillain-Barré, one of those things you are scared for. With respect to Guillain-Barré, that affect the prognosis is what affectation of the diaphragm. So when there's affectation of the diaphragm in an individual with Guillain-Barré, you know that person is going. So most of the time, those ones will be bilateral. So Guillain-Barré is bilateral, ALS is bilateral, polio will be bilateral. So how do you make the diagnosis? So it's very straightforward. Um, Sometimes the diagnosis might just be an incidental finding, right? You can just be doing chest X-ray for whatever reason, and you just notice that there's elevation of the diaphragm, like a section of the diaphragm is elevated. So usually what causes this paradoxical elevation is um, the fact that when an individual is trying to breathe in during inspiration and the diaphragm on that side is not working, what will happen is that the accessory muscles are going to take control, right? They are going to take control and they will try to contract. They will contract and they will pull out the thoracic cavity. They move the thoracic cavity upwards and outwards. So um, this might be, this might cause you know, like a form of paradoxical elevation of the diaphragm. So that's just, a simple explanation for why you have paradoxical elevation of the diaphragm during a diaphragmatic, paralysis situation. So after that, at the back of your mind, you might see paradoxical elevation, you might see no elevation, or no descent rather. You might see no descent, you might see paradoxical elevation. And most of the time, the paradoxical elevation is due to the action of the accessory muscles because of their effect on the rib cage, because um, elevation and outward movement of the rib cage. That's what they do because they are trying to take over the function of the diaphragm. So, yeah, so most of the time, incidental finding on X-ray, you are just going to see that hemisection is kind of elevated compared to the other. So looking at this one now, this is the left, this is the right. You can see that there's a form of left-sided paralysis here, right? We can see that this one is more elevated than this. So that is that. Um, you can do your upright X-ray to look at. It has to be upright. It has to be upright, right? Or you can do what we call fluoroscopic sniff test. So this is very easy. The patient stands up. You are monitoring everything that's happening with your fluoroscopy, which is a form of like X-ray, right? And you tell the patient to sniff. So sniff is just like taking like deep inspiratory breath, like you know, sniff cocaine, sniff drugs, right? So you tell them to sniff, and you track the excursion of the diaphragm with your fluoroscopy. So you are seeing the way the diaphragm is moving, right, with the fluoroscopy guidance. So ideally, if the diaphragm is okay, if the phrenic nerve is intact, you, as the patient sniffs, you expect that both hemisection of the diaphragm to descend, like they should move downwards, right? But if there's a paralysis somewhere, that area will not descend, or the area may be paradoxically elevated. So when you do your forceful inspiration, which is the sniffing, you will notice that the paralyzed hemidiaphragm is going to show a paradoxical elevation. So once you see that, you know that okay, the accessory muscles are taking over and they are pulling up the diaphragm, right? So that is that about unilateral paralysis. Most of the time, in bilateral paralysis, you might not be able to use your fluoroscopic sniff test to make the diagnosis. Let me tell us why. The reason is that um, if you do your sniff, both of them might be elevated paradoxically. So you might not be able to track the normal level that, okay, what should be the normal level? Both of them will be on the same level. So you might not know. So it might not really help you. But what is going to help you would be um, most likely your clinical history, right? Because what you will notice is that they are going to have the signs and features of the heart failure that we have talked about. Difficulty in breathing, right? Exertional dyspnea, the autopnea, the reduced exercise um, um, exercise tolerance, right? They have reduced exercise tolerance, they have autopnea, they have dyspnea, right? And um, if you do your clinical examination, you are going to notice that there's going to be like dullness bilaterally. There's going to be reduced breath sound bilaterally. The reason is that if the diaphragm is not working, please, I'm not trying to make diagnosis of hemothorax or pneumothorax here. The reason is that if the diaphragm is not working, you cannot achieve inspiration. And when you cannot achieve inspiration, you cannot get air into the lungs, right? You cannot get air into those lungs. So if there's no lungs, if there's no air in the lungs, right, it's just like you have atelectasis. When you percuss in a collapsed lung, what do you hear? Dull sound. So it's going to be dull, right? If you try to listen or auscultate, you are not going to hear any breath sound because air is not entering, right? So there's going to be reduced breath sound bilaterally. There's going to be dull percussion notes bilaterally. They're going to have features of heart failure, autopnea, right? They're going to have reduced exercise intolerance, and there's not going to be any fluid swelling, like no fluid collection, no edema. Right? Think about the apoplectic paralysis, right? And if you do your pulmonary function tests, you are going to see features of restrictive lung disease, right? Because they cannot take in air. That's a problem. So it's more like they're having hypoventilation. So they're going to be hypoxemic. They're going to be hypercapnic. And for the hypoxemia, because what they are having is hypoventilation. If you measure the A gradient, what is it going to be? Anybody want to help us? The A gradient is going to be what? It's going to be normal, right? So that's another thing they can even ask us. So what do you expect for the A gradient change? It's going to be normal, right? So somebody that develops trauma after some time starts having all this respiratory stuff that we have talked about, and you did the pulmonary function test, you are experiencing, a reduction in lung capacity, lung volumes. Yeah, because you cannot take in air. And we remember when we were discussing respiratory um, pathology, we said that in restrictive lung disease, they cannot take in air. The major problem is inspiration because there's no space. Either there's no space or they're finding it difficult to take in the air, right? So, you know, they cannot take in air through inspiration. So the lung volumes is going to be small. If you measure the vital capacity, it's going to be small. If you measure the total lung capacity, it is going to be small. So, which is in keeping with the restrictive lung pattern. So after that, as back of your mind, don't never forget that. Don't ever forget that. So you only make diagnosis of the bilateral paralysis with your clinical history. You get the event, the mechanism of injury, you get the history, the presentation, and of course your pulmonary function test.